there's a new paper that's just come out, and if you see, it's the staff that have been involved, Chris Kosmidis, who some of you will know, and Malcolm and David, who obviously they're both retired, but they still help, they still participate in the research, and a guy called Bayu, who I met once. He did some of our diagnostics videos for the training webinars for doctors. He did some of them, and it's been looking at, so you know what we were talking earlier about, when you have a vaccine, some people react strongly to it, some people less strongly, and with aspergillosis, this is it's quite important, because obviously it's not just one specific type of disease with one specific cause. So for example, like the people who are getting COVID associated aspergillosis, like the really invasive kind, that often is people who are fully like immunosuppressed. So people who are on chemo or have had a transplant or something, so the whole immune system is wiped out. And that's when you tend to get the invasive form. But with something like CPA, you quite often can get these authors, they call it a subtle immunodeficiency. So it might be that your immune system is absolutely fine for coping with most infections, and you feel normal in yourself, but there might be just something quite subtle, like a genetic variant that just makes you a bit more predisposed to Aspergillus.
Sorry, Beth, is that the mannose-binding?
That's one of them, yeah.
That's what we did. We did say that the other day, didn't we? Yeah, because I definitely remember being tested for that and being told it was low, and that's why I was always iller than everybody else.
Yeah,
so that would be why I managed, even though it's ABPA, to get ABPA, or is that more to do with CPA patients?
I can't remember which gene does what in this, I'm afraid.
The photographs were over half of the work up there, so I couldn't quite work out how much is hiding behind photographs of people.
Yeah. I can't remember, there's different genes, I can't remember off the top of my head which ones do which thing, but they might do something like, when Aspergillus spores land in your lungs, then they germinate and they grow out these hyphae. So there's kind of several steps before it becomes established, and different genes affect different parts of the process. So it might be like what I think that's to do with clearing the spores, like how fast your lungs can push them back out. So obviously, like somebody with cystic fibrosis, they're not clearing things, they're not clearing the mucus out of their lungs so well, so stuff sticks around more. And then other genes affect the different types of immune cells, and there's all different types of immune cells, macrophages and T cells. So it's and there's a lot we don't know, and especially like on a individual patient level, a lot of people don't get the testing for mannose-binding and the other ones. A lot of people don't ever have the test, so we don't. It's just this huge sort of black hole of things that we don't know yet. I reckon in 10 years, genetic testing is getting a lot more commonplace. I think this is something that will expand, but at the moment there is a lot we don't know, and some of these things they don't just affect how well vaccines take, they can also affect how well the tests work. So that's what this paper is about.
Yeah, that's what I was wondering.
Yeah, because some so with the invasive intensive care side of aspergillosis, it's very well known that a lot of those tests they work very, very differently for someone who's immunosuppressed versus immune normal. Some of the clinical algorithms they use to diagnose you are just different depending on what your immune status is. It's really different. But and that's been quite well known for quite a long time. But this paper is a little bit different because it's looking, instead of the invasive kind, it's looking at the CPA version and the antibody test. So this is quite novel. So what they did was they got 167 people from NAC, so our guys, who've got confirmed CPA, and they tried using different antibody tests to see whether they came back positive or negative. I won't go into the detail. I'm sure nobody wants the detail of what all the different tests do and what they're based on. But one thing they noticed was this immunocap test. It's for the IgG antibody. So that's where your body's been in contact with the Aspergillus fungal burden for a while, and it starts reacting against it over time. And then you can measure the IgG. There was a rate of false negatives, and the people who were testing negative, even though they had the disease, it was, when they looked, it was the people that had these really subtle immune defects. And actually, there's some people have several of the subtle immune defects all at once. So I think some of the people had maybe 4 different subtle defects, and they were still, and they had the disease, and they were still testing negative on this test.
Oh, wow.
And so
it's not helpful.
No, and you can imagine if there's already sort of problems to do with people getting, if there's already problems in the patient journey, if you get a negative test for something, trying to get a GP to listen, and all they see is negative, it does make things difficult. So this is really a problem that does need to be solved. So what they did was then they tried different tests. They tried, I think they tried 3 or 4 in total. And actually, the different tests, depending on exactly how the test was manufactured, some of the tests could pick people up, whereas other ones couldn't. So there's another one by a company called LD Bio, and the reason this is different is it picks up IgG and IgM. And that made it more sensitive. So some of these people that were testing negative, it could find them, which is good. So one of the things, partly it's to do with what antibodies you're producing, and partly it's to do with the different tests, just literally just the way they're manufactured, which it's called the epitope. It's like on the Aspergillus, exactly which bit the antibody sticks to that you're making. Just really fine molecular details, depending on which antibody they use in the manufacturing, they can get slightly different. So in some cases, to get the positive result, you just have to try a couple of different tests. And that's actually something that so I don't know if any of you know Lily Novak-Fraser, who's one of our staff that does a lot of the research. That's something, she did a training video showing doctors how to interpret the antibody test, and that's on the Life Worldwide YouTube. And that's one of the things she said is sometimes you've got to try a couple of different tests. That's just how it is. So it's just another thing that, and it doesn't draw. This doesn't affect everybody. It's kind of a, I think it's 10 or 20%. I can't remember off the top of my head. I've put the link to the paper if anybody wants to read the whole thing. It's free. Yeah, I don't think anybody wants to read the whole thing.
No, I don't.
Oh, I've written it down, never know. On a slow day, when I want to go to sleep, he'll either wake me up or send me off.
Yeah, good sleeping tablet right now.
It is complicated.
Yeah,
it's a problem.
I've got the low mannose thing.
Yeah.
So I thought, oh yeah, okay, I don't really know what it is, but it rings a bell. But
I thought,
so many things I've never heard of.
No, but I thought Professor Denning explained to me the mannose-binding thing was something that affected our macrophages. and it put a shiny film on the bug or something. So it does something to the bug, the infection, that our macrophages then can't cling on tight enough to destroy them. I don't know if that was mannose-binding, but I've just got a vague memory of macrophage. He drew a little picture. Said,
Oh, that's nice. I like a picture.
when you get ill, your own army can't work as well as anybody else's would. That's kind of. I don't know if that's the one though. Is that the one?
That sounds right.
It says that is the way it was.
It is. Oh, good.
Yeah.
I remembered something.
Yeah.
That's why I'm always ill, he said. That's why you're always got the worst cold, ill after, childhood illnesses.
Yeah.
Yeah.
Yeah. But it's interesting because we don't routinely screen for things like that.
No, and you can't say
get
to your
people
GP,
who just think, oh, I'm just one of those people who's always ill.
Yeah.
Who knows?
But you can't say to your GP, well, I've got this worse because, and all through my life, I was perhaps a hysterical child or thought I was ill when I wasn't ill, or, there's probably been lots written about myself as to how well I get and why I get all the infections, and, I'm iller than all my brothers and sisters. It's just been a whole year, lifelong thing. I was so happy to meet him, and he said that. I said, if you have this, then we know why you've never fought the bugs off properly.
Yeah.
And
it's difficult because, obviously genetic testing, it is expensive.
Yeah.
And if there's not, if it's not something that's going to affect the treatment, it can be quite difficult to argue the case for doing it to the people holding the purse strings.
Yes.
Which is, because you get a lot from it knowing what it is psychologically.
Yes, definitely.
But unless it says, don't use that pill, use that one.
Yeah.
It kind of gets bumped down the list of.
I think I started coming up to Manchester at a time when Professor Denning was really flexing his fingers and saying, what could I test these people on? Because I remember coming up and having loads and loads of blood tests every time I came up. Just by the by, let's see if you've got this. Oh, yes, you have.
Yeah.
I'm sure
it's good because the more we know what to look for.
Yeah. But like I say, you can't say that to your GP or your consultant. So, well, I'm not getting any better because I've got mannose-binding protein deficiency or whatever. You can't go in and relay those things to another doctor, can you? Because they're probably not interested.
No. But the advances so I used to work for the genetic testing service down in Birmingham, and just every year the amount of progress being made on making things cheaper, screen for more things at once, it's fantastic. And they were starting to bring in things so the old-fashioned way used to be, we think you'd have to guess which gene was wrong, and then you could test it and it would say normal or a pathogenical variant. You're not supposed to say they're mutants because people get upset. But you'd have to sort of guess and then test it, and then if that wasn't it, guess again, test the next one, and it would sometimes take years to find out what the problem was. But now they're starting to bring in, you'll take one sample and seek everything all at once, all the data, and then you can just go in digitally and say, is it this, compare it against databases of known problems. So 10 years from now, it's going to be a whole different ball game.
Amazing.
Yeah. 10 years is a long time though, Beth. When you're 62.
Okay, 5 years then, 5 years.
Say 5 years, say 5 years, 2 years.
Yeah, say 5 years.
Every year every single year it's amazing stuff's happening.
Yeah. It's nice to know that it is getting faster.
Yeah, and there's one trial that they're looking at in Spain. So with some antifungals, you have to have the therapeutic drug monitoring, like checking the blood levels to make sure it's. because you get some people that metabolize it really fast and some that metabolize it really slow, and you can end up either not treating or poisoning people if you get it wrong.
I've had each end of that, depending on what.
But yeah, I mean, you can go too far one way. It's difficult. So in Spain, they're doing a trial where people who know they're going to be at risk of the invasive aspergillosis, so like people that are going to have chemo or a transplant, they're testing the genes for metabolizing the antifungals before they start.
Excellent.
And then they're seeing whether that helps, like when they do get infections, whether it helps keep on top of it, which I'm really interested to see the results of, because we don't routinely do that here.
No, I mean, I would be interested because, you know, I worry that if I did get COVID, this was my biggest worry, that if I did get it and then the Aspergillus then had a party because everything was going off in my lung, that I don't have any antifungals that I can use because my body's become, well, I have, you know, azole resistant Aspergillus. So what the heck would be left for me?
Can you have amphotericin, or is that not really?
Sorry?
Can you take amphotericin?
That's what I'm using at the moment, but that also doesn't work on the Aspergillus fumigatus. It might work on the Niger, and that's why Professor Delling let me carry on, because he basically said, well, we can't do anything more because you've got this now. And I said, well, I've got it at home. Can I just keep using it? And then the next time I went up there, I'd got the new, you know, Niger as well. So he said, you know, keep trying, because that, you know, that might help. That's all you've got to do. Hope that you don't keep that forever and that something new will come up.
I mean, there are things in the pipeline. It's just how quickly it actually, and even once the trials have been done, sometimes the gap between the paper's been published and you actually can get it in your hands from the pharmacy.
It's a long time.
No,
but it's good. I like to hear that things are coming on apace, and that if I can get my vaccine in a little while, I've got to go soon, in a little while, and that'll be the first step towards not having COVID to that.
Okay, exactly, Kate.
There are positives. It's
definitely.
I think the news focuses very much on the negative, but there are positives out there. It's just
because like when you're at home on your own a lot, all you've got is what's going round and round in your head, and if you're up till 2 o'clock in the morning, it's going round in your head. You think, well, you know, how am I going to fight this if there isn't anything to fight it with? Or you know,
I had a brilliant word for, you know, when it's 2 o'clock in the morning and you're just going through Facebook and all the bad news.
Oh, I don't do that.
Scrolling.
I don't go on Facebook. That'd be desperately bad for me to go on Facebook in the middle of the night.